Hello, this is Dr. Joseph Klumpen. I'm a medical oncologist, and my full name is Heinz Joseph because I'm of German origin but live in the Netherlands. What I do today is I will give you a presentation about what we have done for the cholangiocarcinoma in the Netherlands over the last decades. I give you a summary of that. I have not participated of all the decades, but a part of it. So the Netherlands, just to give you an overview, is a small country. It's a democracy. The capital is Amsterdam, where I'm right now. Seat of the government is Den Haag. We have a population of 17 million people, and the life expectancy is 81.4 years with a low unemployment rate of only 3.3%. We have 79 hospitals, of which 8 are academic. And the insurance is a private but non-profit insurance. The cancer incidence is about 16,000 patients per year with an average age at diagnosis of 69 years. The 5-year survival is about 64%. In regards to financing the whole system of healthcare, the healthcare spending at the moment is about 11% in total, of which 5% is the healthcare spending for cost of cancer care. So it's about half of it. So the Netherlands is the country as depicted here, with lots of different provinces, and these provinces have a different incidence of cancer per region, as you've seen here. They're not very big differences, but they are. In regards to the cholangiocarcinoma, I can show you here that the incidence rate has changed over time. We've recorded the incidence since 1989, and we'll see that it has already nearly doubled since the beginning of the 2000s. So I was asked to give you perspective of the Netherlands, and I thought I'd start with a historical perspective as well, just to give you an idea of the Netherlands itself. The first hospital was here founded in 1252. The first university in 1575 in the town of Leiden. This famous picture everybody might know is the anatomical lesson from Dr. Nicholas Tulip, and it's in 1632 performed. The next one is a big range until we come into modern days. In 1913, the first cancer hospital has opened. It was named after the famous Antony van Leeuwenhoek, who was researching with the first microscope. In 1949, the Dutch Cancer Society, one of the major funding organizations for cancer care, was founded. The first university medical center is in Amsterdam, was founded in 1983, and I'm part of that hospital right now. This is the first university medical center, the AMC, and at the time it was built, it was the largest building in Europe. So for a small country, they're going big steps. So the university medical centers, Amsterdam was the first, and later a few others came. In total, there are now 8, and the most recent merge was in Amsterdam because there were 2 of those, and now they're combined to the Amsterdam University Medical Centers. And as you see, in some major other towns, there are university medical centers as well as Rotterdam, Groningen, Utrecht, Nijmegen, Maastricht, and Leiden. There's a federation of those hospitals founded in 1989. That's a very important federation. And it was also in the same year, the National Cancer Registry was founded. That cancer registry is extremely important, which I will show you later. In 2014, the Dutch Hepatocellular and Cholangiocarcinoma Group, the DHCG, was founded, and I was honored to be the chair of their first years. What I want to do is to show you a few important people in the country who started the care and research for this disease. It's Thomas van Gulik. It's one of the, from the start of the AMC, he was part of it. He's a liver and bile duct surgeon. and he has retired, but I asked him to tell me his most achievements of his life. So what he's done in the last 30 years, he has standardized the surgical approach for biliary tract cancer. He has also done the analysis of benign lesions mimicking perihylar cholangiocarcinoma, like the IgG4 disease. He also described the definition of criteria for preoperative biliary drainage in perihylar cholangiocarcinoma, and also risk reduction in surgical candidates through assessment of liver function and portal vein embolization, which is a specific technique to reduce the complication rate and increase the chance of curative resection. Another very important figure in the Netherlands was Erik Rouse. He is a gastroenterologist. He is the expert in the field in the country in optimization of stenting of bile duct obstructions, and also he has retired. Just to go into details of the disease and what we've done due to the institution I have spoken about, we were able to do retrospective analysis. And as you see here, and you can find it yourself online, if you just use the www.iknl.nl, and I also added for you in English the EN part, then you can look it up and you can find, you can do your own research, you can produce these sort of slides yourself, and it will show you what the survival or incidence or whatever rate there is over time, and starts in the 70s, as you see, and we can see here that the 5-year survival rate has increased and nearly doubled from 37% in the 1970s to 2011, it's already 65%. So that is a big achievement, and you see here that over time it has increased by decade. So other parts of the retrospective analysis, which have been founded by the National Cancer Registry. So they have collected the data of since 1989. And so there are 3 points to get the data is from hospital admissions, pathology results, and the cause of death certificates. Since 2011, specifically for the biliary tract cancer, we have the subgroups per type. So that's very important. Also, the data on diagnosis and treatment is available in this registry. There's a collaboration with clinicians, that's the IKNL. So people like me are involved, and people of the Cancer Registry are involved in the working party. And there's also collaboration with patients group, the NFK. So in the Netherlands, it's very important and to mention here the centralization of care for biliary tract cancer. So we have another institution, it's the SONCOS. It's a collaboration of clinicians, and the main goal is to find minimal criteria for cancer treatment per tumor type. That means there is also a minimal number of patients treated per year in order to be able to take care of those patients. That has helped a lot to centralize care. Another is that we started the guideline in 2013 and finalized it in 2014. And an update is coming in 2021. So this year, and this helps a lot because also insurance companies have a look at those guidelines to see what is being reimbursed in which hospital. So the National Working Group, as I said, the DHCG, has a goal, it was founded by the Guideline Committee, and it started clinical trials, coordinate respective analysis, but also started biobanking for this disease and the scientific approval of grant applications. So what has this HEL group achieved over time in research? So in regards to retrospective analysis of the data, data source I've just shown you, we've done many things, and I'll just put a selection out here. So the validation of a staging system we have performed, compliance to guidelines we have checked, we found prognostic factors of recurrence of perihilar cholangiocarcinoma with a nomogram, which can be individualized to each patient, and the same for distal cholangiocarcinoma we have done recently, and it was accepted for publication, but it's not available as yet. We have looked at the in Great Britain, it was found that GEM-CIS is a standard of care for advanced disease, and we had a look if the landmark study criteria for inclusion are necessary to depict patients, but it seems that it's also outside the landmark study criteria if the treatment is effective. Also, for distal cholangiocarcinoma treatment, we've given an overview of all patients in the country. Also, the role of low-dose radiotherapy preoperative for perihilar cholangiocarcinoma. There's also an overview of gallbladder carcinoma recently published. This is, as I said, just a selection. One of an example, which I use still on a daily basis to talk to patients about their chance of recurrence of disease and to talk to them about the adjuvant treatment options. So this is a way to, you can see here some factors have been found to predict prognosis, and therefore you can count on the survival rate for 3 or 5 years, and that might help to find the right treatment. There are some clinical trials we have started, and this is an overview, and I will give you a few examples. So we have looked at the IDH mutated disease in intrahepatic cholangiocarcinoma, the role of FOLFIRINOX in second line, the best drainage for perihilar cholangiocarcinoma, the ACTICA trial, which is still ongoing, and an adjuvant trial, the ALPACA trial for local advanced perihilar cholangiocarcinoma, the STRONG trial, the PUMP2, and the SAPACHA. I will give you some examples, and also want to tell you that we participate in many industry-driven studies. And so when I say we, then it's a selected group of centers who are specialized in this disease. And I can proudly tell you that because of this centralization of care, this small country is for many studies top recruiter in the Western world for these studies, far ahead from America and Germany, countries I don't have to tell you, which are much larger than the Netherlands. So this is an example of a successful study. We performed a second-line study of modified FOLFIRINOX in 30 patients, and we could show an overall survival of 10.7 months and a response rate of 10%, a progression-free survival of 6.2 months. Another study, which unfortunately was prematurely terminated, was a drainage study. We were trying to find the best way to deal with bile duct obstructions, either percutaneously or via ERCP. And that study has been finalized after 50% of recruitment because of high mortality in the percutaneous drainage group. Unfortunately, the question has still not been answered because there was another study in the United States that also had to be terminated, but this time because of slow recruitment. There was a meta-analysis performed, and that showed that the question has not been answered as yet. So we are working currently on another treatment design for this study. Another very impressive study is the PUMP2 study for locally advanced intrahepatic cholangiocarcinoma. It's a phase 2 study of 35 patients to see the effectiveness and safety of intraarterial chemotherapy next to systemic treatment. A study which has been performed and finalized is the ALPACA study, where we do the NanoKnife treatment followed by GEM-CIS for locally advanced perihilar cholangiocarcinoma, which is a safe treatment. And also there is some work in progress. What we try to implement is the value care medicine the induction treatment for locally advanced disease to increase the rate of resections. Also, we organized an expert consensus for resection criteria because there are no resection criteria for perihilar cholangiocarcinoma as yet. We are currently working on a national and international guidelines together with the ESMO and European organizations. And one of the biggest goals for our pathologists is to standardize the pathology reports, and that helps to have the right registrations, which help again the quality for retrospective analysis. We cannot do this alone. We have to have help of a national, international level. As I told you before, we have a national working party, but we're also working together with the ENSCA group. We're part of the COST grant we've achieved, and we are part of the Eurocan network, but also patient organizations for cholangiocarcinoma, such as the AMF and the American Cholangiocarcinoma Foundation and the Dutch NFK. There's another international group as the International Biliary Tract Cancer Collaborators, mainly by the medical oncologists, but I'm pretty sure some other presenter will talk about this more in detail. And also to show you some names and people I work closely with in Europe, like Juan Valle, Jesus Benales, but also Jean-Yves Blay from the Eurocan team, Vincenzo Cardinale from the COST team, and John Bridgewater, of course, from London, who is the president of the IBTCC. So in conclusion, the Netherlands is a small country, but due to the good collaboration between centers and disciplines, in combination with centralization of care, with a high, gives us a high standard of clinical care and a high output of research for biliary tract cancer. This is a selection of the group in the Netherlands of people I would like to thank, of course. And I'm looking forward to the questions. Many thanks.